Welcome to today's episode of Oncology Data Advisor. Today I'm joined by Dr. Alankrita Taneja and Dr. Matt Hadfield, who are here for a discussion of National Overdose Awareness Day, which is taking place this year on August 31st. Thank you both so much for coming on today.
Thank you for having us.
Thanks, Kiara. So I can briefly start about, the topic of discussion today. So as we all know, there has been an opioid crisis, and that has led to a lot of problems for patients and physicians, prescribers. There was a letter from the Surgeon General encouraging all US physicians to restrict opioid use due to this crisis. And there have also been new opioid guidelines from the CDC, which recommend that prescription drug monitoring databases need to be checked before prescribing opioids. Now, while these limitations do help us prevent the propagation of the opioid use disorder, but for our cancer patients, it's particularly problematic because, as we know, our patients have a lot of pain needs, and opioids continue to be the best pain medication that we have for patients for various reasons, such as the fact that they don't cause any organ damage, and they don't have a ceiling effect. They are almost immediately effective when we prescribe these to our patients. So they do remain to be an important medication for us oncologists to prescribe. However, because of these limitations, patients with cancer have also been affected, and have had these regulations have only had unintended consequences for our patients as well. These limitations have also occurred in the form of opioid shortages, which has resulted in delays caused by opioid pre-authorization requirements from insurance companies. And as studies have actually shown that the morphine equivalent daily dose prescribed by oncologists before referral to supportive care in the recent years has decreased from 78 to 40 milligrams, and this is in the last 6 years. However, we should also consider that non-medical opioid use is also a phenomena that does exist in our patients as well, and we need to screen appropriately for it. For example, there was a recent study that showed that opioid-associated deaths in patients with cancer from the year 2006 to 2016 was 10 times more in patients with cancer as compared to patients without cancer. So, and this was a study that was consistent with a prior study from the Veterans Affairs Health System, which also demonstrated similar results. So, there is mounting evidence that patients with cancer who receive opioids are also at risk of a higher dose and higher risk of non-medical opioid use than was previously believed. What do you think about that, Matt?
Yeah, you make some really remarkable points and bring up some really important topics for discussion in this area right now. I think to be honest, and I'm sure you've had this experience, I've met an enormous amount of patients who, when I meet them for the first time, have pain related to their cancer, particularly patients with metastatic disease that may have, osseous lesions that are causing pain and are very hesitant to want to be prescribed opioids. So I've certainly met patients that are, against taking any type of pain medications because of the awareness around the addictive potential of opioids. And I've certainly met patients as well who have a history of, substance use disorder or opioid use disorder who, unfortunately do sometimes misuse the medications you prescribe. So I think it's a very, very complicated and hard topic of discussion that we should all be talking a lot more about. I think, to be honest, it's really important to understand your patient and what their pain needs are, and make sure it's adequately being addressed. And I think, in my experience, having support from palliative care physicians has been really helpful as well, particularly in patients who have prior substance use disorder, because unfortunately, I think we've all seen that these patients, while they do have a history of potentially abusing things such as opioids, they also have organic pain that needs to be appropriately addressed. And sometimes those patients are just not managed the right way. And looping in specialists including oncologists, but also palliative care is just wonderful in this area, that are able to, provide support and managing those patients is really critical, because really at the end of the day, you want to do the least amount of harm to patients as possible while you're treating them for their cancer, and whether or not that means they're in pain and they don't understand that there is, organic pain that needs to be addressed with opioids, and that's the indication for opioids, or if they're, at risk of overdosing because maybe they do have a history of substance use or addiction, and even beyond that, some people just, their renal function is decreased because they're older, they may be at more risk for polypharmacy, maybe at more risk for overdose. So making sure that we're really in tune to these things is really, really important.
Right. And I think when we see patients, we have to assess them at various levels. And to limit the non-medical opioid use disorder, we should start with the pain assessment as well. While we have established that opioids are the primary pain medications due to their efficacy, tolerability, safety in cancer patients, and, since the opioid crisis several years ago, we haven't really come up with any other pain medication that is as effective. So we have to continue prescribing these drugs. However, there are some indications in cancer patients wherein we can think about prescribing them a non-opioid pain medication. For example, in neuropathy, which is, for example, in multiple myeloma patients, there can be peripheral neuropathy due to various causes. And, I, in my practice, have often considered something like duloxetine, which can be as effective as opioid medications and even better in some ways. And for example, if our patients have other causes of pain, such as, Matt was describing, they can have other issues ongoing apart from cancer-related pain, such as fibromyalgia. Opioids are not a first line in fibromyalgia, wherein, we would consider some antidepressants and anticonvulsants as well. Musculoskeletal pain, sometimes NSAIDs can work if they have appropriate kidney function, of course, in patients with bone pain. So, starting there could also help us limit additional opioid use in
No,
our patients.
absolutely. I couldn't agree more with that. I think sometimes we get too fixated on pain, with good reason. You never want a patient to be in pain, but at the same time, sometimes we manage pain and a dose escalation where we just keep increasing doses, we keep adding other pain medications, and sometimes we don't ask enough questions about the etiology of the pain. So to your point, sometimes neuropathy can be treated with, as you mentioned, duloxetine or gabapentin. And sometimes patients have musculoskeletal pain. A lot of them have, comorbidities that limit their mobility, including their cancer. I've had excellent results with having patients seen by PM&R specialists who work on functionality, as well as physical therapy, occupational therapy, in-home services, all of which can, increase someone's functionality. And to that point, to reiterate what you'd already said, I don't think we address underlying depression and anxiety in this patient population enough, which we know has somatic manifestations as well. So really taking a global look at the patient and ensuring that we're addressing all their needs, not just pain, and not, and de-escalating pain medications when we can, because, in addition, we're talking about potential overdoses, which is a horrible thing, and unfortunately does happen. But, constipation from chronic opioid use is not a trivial thing. It really does have a significant impact on a patient's well-being and outcomes. So yeah, I completely agree. Looking at all those things and trying to optimize other medications when you can, and really titrating the best regimen for them is critical.
Absolutely. And, just adding to that about assessing the patient wholly to see what all factors could be contributing to an increased pain threshold or, lower pain threshold. For example, patient's coping style, their emotional responses, anxiety, depression, do they have any other grief or suffering that is causing them to require more, somatically, like Matt was mentioning, requiring additional pain medications. Do they have delirium? Because it is known that cognitive impairment, such as delirium, can be present in 30% of patients with cancer who are seen by palliative care teams, as per a study. And more than 60% of those have actually not been previously diagnosed. So we need to, make sure that we are diagnosing these patients. A third of them can have some underlying delirium, and opioid use is a major contributor for delirium. So we need to make sure that we do not over-prescribe, or, we are more careful with prescribing the dosages of opioids that we are in these patients. And we should also try to understand from the patient what their beliefs regarding pain are. How do they, because it's a very subjective thing, and we need to ask them what pain means for them. What does a non-medical opioid use mean to them? Are they are they having a thought process of using opioids apart from what we are prescribing them in the clinic? And do they have any secondary gain from this? Also, sometimes social cultural aspects need to be considered, such as the caregivers. People who have less caregivers tend to ask for pain medications more. What their family dynamics are, what their cultural background is, or all of these factors can play a role, and we need to assess our patients appropriately before prescribing opioids.
I couldn't agree more. So, to be honest, one thing that you touched on at the beginning of our conversation was, the multiple ways in which you can monitor patients for where they're getting prescribed opioids and where they're getting them refilled. And, there's all these restrictions now. And unfortunately, sometimes when, again, we can get so fixated on someone's cancer that we kind of lose track of the whole picture. And, people come from all different socioeconomic backgrounds. People come from all different types of living situations. And if you're not paying attention to those things, you could potentially put someone at risk or harm. And, asking who helps with your medications, how often is someone coming to help you with your medications? For instance, elderly patients, there's that risk of having their medications taken by, someone that's has access to them and either using them themselves or in some other way. And unfortunately, those are just the difficult conversations as physicians and providers we have to have, because if we don't, oftentimes those things don't get teased out. And we're in that position as the prescriber to kind of look into those things. And unfortunately, I have had situations where that's happened, where someone's pain medication was being taken by a family member. So they were getting frequent refills, but they weren't actually taking the medication, and they were getting help with their medication. So they weren't actually taking the opioids as they thought they were, as they were prescribed. So again, we're in a unique situation to make sure that we take care of people and ask even the difficult questions like that, and look into maybe those situations that can be uncomfortable for providers, but are really important.
Right. Even though they're uncomfortable, we need to know about them and, suspect, if we have something suspicious going on, we should just keep ourselves aware of the fact that this can happen. And we will talk later about the monitoring strategies for patients with on opioids. So we need to follow those regulations as well in order to make sure that there's not a risk of a use disorder. But there's actually also questionnaires and risk assessment tools that are objectively available, which is great, that we can use. And they actually take less than 5 minutes to administer in each visit. And they could be relating to general substance abuse, as we were talking about earlier. If somebody has a history of alcohol use disorder, so using the CAGE questionnaire can help us assess whether this patient could also have higher risk of overusing the opioids we're prescribing them. So the CAGE questionnaire, and then the CAGE aid questionnaire, which is cut down, annoyed, guilty eye opener tool, as well as the adjusted to include drugs. Then assessing their psychological distress using the Edmonton Symptom Assessment Scale or the distress thermometer to see if they have a lower tolerance to pain as well due to their underlying distress. And then there's specific screening for non-medical opioid use, such as the using the ORT and the SOAP tools, which are the opioid risk tool, as well as a screener and opioid assessment for patients with pain tool. And this is at the time of initial or before the initiation of opioid therapy. And then after opioid initiation, as we were mentioning that there are some patients who are not using these pain medications or getting pain medications elsewhere. We need to make sure that they're taking what we are giving them. We can use urine drug tests as well as the prescription drug monitoring program, which varies by state, I believe, but it kind of tells you where all the patient has filled in their opioids in the last few months, and it can help us find out whether we are the only prescribers or do they have additional providers giving them additional doses, making them at risk for using higher doses and therefore overuse.
All really great points, and highlights a lot of tools that we can use to try and minimize over prescribing. And I think that's an interesting area as an oncologist. I think we get into quite frequently is that oftentimes when people become our patient, in some situations that we really become their primary physician in many ways. So really having that conversation with their PCP, saying, I'm managing this, you're managing this. I just want to make sure this is clear, to avoid those situations, because especially as, I'm sure I'm not sure if this is like this at your medical center, but we have outside offices that don't sync with our EMR. We don't necessarily get notes. We don't necessarily get, records in a timely fashion for PCPs that are seeing our patients. And, you certainly, if you're changing medications, including pain medications, but also the primary care physician that's also another area where errors can unfortunately happen. So we have to be diligent about that.
Absolutely. So, I would just like to conclude by saying that there is, a tendency even for our patients with organic issues such as cancer to have an opioid use problem. And, the Drug Enforcement Agency, the Drug Enforcement Administration, the CDC, the Surgeon General, everyone has, different regulations in place to ensure that opioids are not being overprescribed. And, and unfortunately, this does not exclude our cancer patients. So we need to be mindful about prescribing opioids and assess the patient appropriately. Make sure that we are assessing their other risk factors for abuse, as well as monitoring them appropriately. And also, like Matt was mentioning earlier about the side effects such as constipation, that is another actually sign if patients are having a lot of side effects such as constipation, respiratory depression, things like that. That's a sign that maybe the opioids that we are giving them are higher than what we need to. So that gives us an opportunity to monitor. I'm not saying definitely that's a sign that they're overusing, but it could be that if you're giving them less dose, that could be a sort of point where we can intervene and monitor and assess whether there is a risk for opioid use disorder in those patients. So we just need to make sure that we're using all these strategies.
Absolutely, couldn't agree more. It's a really important topic, and I'm glad we had the opportunity to discuss it today. And I think the one thing that I would conclude with is that you have to get to know your patient, whether or not they're at risk for not taking pain medications because they're scared of them, or if they're at risk for using them inappropriately, or anywhere in between that spectrum. You want to make sure that you're taking good care of the patient and that the patient's safe and that you're doing things the right way. So it's really important to have those conversations often and frequently with your patients.